Again, the third thing is we coming inside the lumen. Inside the lumen, we need to do an endoscopy because we have ruled out the metastasis. We have got some idea about the regional spread. Now we want to see whether there is a response from the tumor. So to assess the response, we do an endoscopy, see whether there is an ulcer still existing, whether there is a tumor still existing, because once you see an ulcer or a tumor still existing, that means there is only partial response. The probability of having the cancer in that lesion is higher. So when there is scar tissue post-neoadjuvant therapy on endoscopy, that means there is a possibility of pathological response. Then we target biopsies on that lesion. We do a bite-on-bite technique where we keep taking bites from the same place so that we'll be able to reach deeper tissues, and the positivity of chance of decreasing the false negatives is higher. And endo-ultrasound is definitely useful in assessing the T stages, particularly the early T stages, T1 and T2, and the nodal regional lymph nodes in these cases. And it will help us guide to take the biopsy from the exact location that we need to do. And in case the patient is not a surgical candidate, or in case the patient has opted out of surgery, then this is the scenario where endoscopy is very helpful in active surveillance of these patients. So again, the limitations are fibrosis and residual tumors is very difficult to assess unless and until there is a physical evidence of an ulcer or a tumor lesion there. And sampling errors are higher. And again, it was previously discussed in the last session how we can reduce the sampling errors and all. So assessment of lymph nodes with endo-ultrasound is useful, and predicting pathological CR with the help of biopsies is useful. Then bronchoscopy. Bronchoscopy has a limited role, and it's mainly based upon the clinical scenario the patient presents with. If the patient is having chronic cough, and if he's, sometimes patients say that in cough they expel that food material and all. So all those things, when you see there is hoarseness of voice and all, then we have a suspicion that tracheobronchial tree is involved. So in those cases only we do a bronchoscopy. Otherwise, when you have a close contact between the tumor and the tracheobronchial tree on an imaging, axial imaging, we do a bronchoscopy. So what do you want to see on bronchoscopy? We want to see whether there is airway invasion. We have to look whether it is a compression or direct infiltration. And if needed, we take biopsy out of it to prove it. And then we have to assess the resectability in the post-NACRT. We do bronchoscopy in these cases. So airway patency assessment is very important before surgery. So bronchoscopy, when the lesion is close to carina or upper esophageal tumors, it's very useful for us to do a bronchoscopy to assess the airway patency. And any persistent respiratory symptoms, we have to suspect tracheoesophageal fistulas and invasion of the tumor. So the limitations are it's not used for routine staging, but definitive role is there in case of any suspicious lesion where the tracheobronchial is involved. And again, challenges in biopsy interpretation and assessment of lymph nodes is real. So timing of surgery, we have a lot of studies. There are studies which have suggested short follow-up, medium follow-up, and long duration follow-ups also. But what is generally accepted is 6 to 8 weeks post NACRT surgery is when it is recommended, because the delayed approach will increase the pathological complete response and tumor downstaging, but the potential of increasing the morbidity, particularly the anastomotic leaks, is higher. The chance of spread of the tumor is higher in case there is a delay between surgery and the NACRT, and the tumor progression is a reality, and then it also increases the surgical difficulty because of the increased fibrosis in those situations. Surgical difficulties, it will arise from radiation mainly, and the chemotherapy effects are real. So what we expect is technical difficulties when we are doing surgery, like when there is a fibrosis, it will become more difficult to operate. There will be a lot of inflammation, bleeding chances are high. Injuring the thymus is higher. Injuring the recurrent laryngeal nerves is higher. And in case the conduit that we are going to take is in the field of in the field of radiation, particularly GE junction tumors. So conduit might necrose, and anastomotic leaks can increase. So all these problems will be there, and post-chemo radiation therapy, because of the nutritional status and other pre-existing conditions like lung disease, post-radiation and all, they'll increase the complication rates. So how do we mitigate this? By careful selection and preoperative planning and optimizing the time of surgery. As of now, only 6 to weeks is ideal. More than 10 weeks, it increases the morbidity as well as anastomotic leaks. So unless until you don't want to operate and you just want to follow these patients with assumed pathological complete response, you can just follow up these patients and you can take up those patients whenever they have a recurrent tumor. Thank you.